Well, hello everybody, and thank you very, very much for joining this Royal College of Surgeons of England webinar. We're talking this evening about the New Deal for surgery. We'll say a bit more about that in a moment. I've got a great panel with me, and I'm going to ask them to introduce themselves one by one. First of all, Stella Wieg.
Hello, so my name is Stella Wieg. I'm a Royal College of Surgeons Council member, but also a consultant vascular general surgeon based down at Croydon and the London GERF lead for general surgery.
And Sas, thank you.
Hi, thanks. My name is Sas Banerjee, and I'm a colorectal surgeon at out in North East London, the hospital called Queen's Hospital and a sister hospital called King George Hospital. I'm also the regional director for North East London and the clinical director for endoscopy for London.
Okay, and then Tamora.
Hello, I'm Tamora Langley. I work at the college. I head up the Policy, Media and Public Affairs team.
Great, and Lola Giwa was going to join us, Asset President, and we just met her virtually in a cafe halfway home, running to an emergency back home, and of course we said she had to attend to that rather than come to the webinar. But we promise, represent trainees' points of view over the whole issue as we go along. So next slide, please. Okay, so when there's a crisis, there's an opportunity. And when we speak to our political and government masters, they prefer solutions to problems. And so was born the New Deal for surgery, mirroring, not in any way being particularly creative or original, FDR's 1932 New Deal, which was all about the recovery of the United States economy from combined effects of the end of World War I and the Great Depression. And it completely reinvigorated the American economy such that it became the biggest economy in the world throughout the war and afterwards. Thank you very much. Next slide, please. So in FDR's document, they described relief, recovery and reform, and we're going to be doing exactly the same in our proposals around recovering surgery after the pandemic, of restarting surgery after the pandemic, of a new deal for surgery after the pandemic. We're talking about relief, supporting our staff to get going again. I heard some stories today from Kent and Surrey, how the surgical staff are finding that the unintended consequence of the demand for getting numbers up is that the staff are getting very, very frazzled and very tired and fed up and thinking of leaving. So there's a big supporting staff role here. Secondly, there's actually the recovery of elective surgery. Some people suggest that it needs to be 120% to make even a dent in the enormous backlog. And then obviously, if we go to our political masters, they won't give us money for same old. We have to suggest a reform of the services in such a way that we improve productivity. All these things incredibly difficult at the time of both the tail of the pandemic, we hope, and obviously major, major, major threats to the UK economy. Next slide, please. And you all know the problem, 5 million people now on the wait list, and some have estimated a hidden wait list of nearly 10 million people. Those who haven't come forward yet, hidden cancers, people undeclared hip problems, etc., etc. There is the overlay of the pandemic on the pre-existing undersupply of NHS beds. And even before the pandemic, we had periods, for example, in 2018, January, February, when elective surgery was paused. So this isn't a new phenomenon, but it's really, really brought it into focus. Next slide, please. So the essence of the recommendations of the New Deal for surgery are, let's be sure there is consistent ongoing investment in the elective recovery for the next 5 years, because trusts and integrated care systems can't make complicated plans with capital and revenue unless they know where their money is coming from. we need to increase the number of hospital beds. We're much below the ECD average. And one of the things that certainly caught the press attention and the politicians' attention is the idea of surgical hubs. Surgical hubs away from acute medicine, away from viruses, away from the vagaries of maybe there's a bed, maybe there's not, an area of certainty and an area where surgeons can get momentum over getting surgery done. And then obviously we can have all the hubs in the world, but if there's no workforce to make it all work, that's completely hopeless. So we have to address work shortages too. And you can see on the right there that bed capacity in NHS England has fallen over that period. And I can remember a former Minister of Health, Virginia Bottomley, saying hospitals won't be needed in the next 10 years. It's all about the bedless hospital. Well, well, well. Next slide, please. So it came out at the end of May, beginning of June, and there've been lots of good positive responses, and we'll be talking about how that might work in practice. We're going to be talking about ideal exemplars of how it might work or has worked, and then we'll be talking about the bigger picture. And obviously in all this we have to take into account the massive effect of the pandemic on our trainees, and of course getting going again with all the pressures on numbers and on the staff. It's very easy to see training go out of the window, and we mustn't let that happen. All incredibly difficult things to combine. But we're going to hear a little bit more about recovery, a new deal, hubs, and how people are managing on the spot. First of all, from Stella Wiig. Stella, thank you.
Thank you very much, Neil. So what I would like to do is to show you where we were in Croydon. If you can go to the next slide, please, Eduardo. Where we were in Croydon and where we've got to now, and it's a journey. And Neil, you talk about a new deal and a new opportunity, and I think we've begun to carve that out of Croydon. So if we may go to the next slide. So Croydon, in the height of the pandemic, we've got a huge, diverse community. We're a district general hospital. 32,000 patients with COVID in our community, 3,000 treated at the trust. As many other places, our critical care capacity was completely exceeded. Main theatre recovery became an ITU. My lovely vascular ward became a CPAP ward, and so came with it the deaths that occurred at Croydon, because we had such an impact at Croydon. Elective surgery came to standstill, and there was almost no access for cancer. And so all we did was about 30% of our normal elective activity, which was some cancers and some urology cases. Everything else was at standstill. So if we may go to the next slide. So what could we do next? And Neil, you talked about planning a restart, and in Croydon we had an operational recovery board. There was a system leadership in southwest London, and the words really that have to underpin everything we've done is collaboration, teamwork, using our resource, and that's across the piece, asking people to do things in different ways, because actually we discovered that they could, through COVID, do things in different ways, and everything underpinned by infection prevention policies. So the system approach was looking at different work streams, and we were involved in the planned care and cancer. And what was really key to everything was the clinical and operational voice joined together to ensure that we did the right thing. And that was clinical review of our waiting list with clinical prioritization using the college guidance, local ownerships of our waiting list, which I think we've lost over the last 20 years, overview of access policy and patient choice, understanding well-being, which can't be emphasized enough, of all our staff, and learning from the first wave so we didn't do the same again in a rush. And if we may go to the next slide. And so where there's a crisis, there's an opportunity. So what did Croydon do? Croydon became an elective hub, but we did things in a slightly different way. And the concept of a surgical hub, when it initially started, was of a ring fence, a single speciality working through the waiting list. We thought we would do things in a slightly different way because our estate allowed it, and we separated from the elective flow. So we developed what we call the Croydon Elective Centre, strictly protected COVID-free zone, separate entrance that was put into the second floor, a dedicated 28 ring fence beds, which I have tried to do at Croydon for the last 15 years. Summer crisis, we've managed to conserve our beds. A 12-bedded children's area, which is our dolphin unit. We implemented 4 new surgical enhanced care level 1.5 beds. Ring fence for cardiac cath lab, put in a new restaurant and some facilities for the staff, and in doing so, converted our 10 theatre complex, which was our main theatre complex, into the elective zone, and converted our day surgery unit into our CPOD trauma and emergency surgical centre. And in protecting that, the strict infection control policy went in, but what was again key to delivery was this was co-owned, co-developed with everyone involved. Anaesthetists, our trainees, surgeons, operations managers, porters, everybody had a stake in what we did. If we make it to the next slide. And in doing this, we started to rally the troops who felt very, very uncomfortable with thinking about starting elective activity again. And Croydon has had a long-standing interest in day case, but the Croydon restart was everything was day case as a default. And as you can see, our day case rates pre-COVID were high, and our conversion rates have been under the national median for a long time. The clinical support that was needed was the pre-assessment with virtual first, overbooking our list by 20%. Our anaesthetic colleagues were fabulous with blocks and the high-risk pre-operative pre-assessments. The clinical validation and ensuring there was no surgical regret in our waiting list. The patients came in and were treated as they needed to, and if it was now inappropriate to treat them for whatever reason because they'd waited so long that either their condition had improved and they didn't need surgery, or actually their condition had changed in terms of their physiology, that actually maybe the operation wasn't appropriate again, that we had those conversations up front. We looked at theatre utilisations, 3-session lists, 6-day working, and of course enhanced pay rates for our nursing staff in particular. Next slide, please. And in doing this, what we developed, we had a go live date. We've just had our birthday today. It's the Croydon Elective Centre's first birthday. So we went live on the 6th of July last year, and we went back to 100% of our business as usual within 6 weeks. And we maintained that all the way through until the second wave hit in December. But despite that, with doing things differently, we maintained 60% of business as usual through the second wave of COVID. And that for us is important because Croydon normally, through winter pressures, stops. Next slide, please. So what do we learn in second wave? Well, our critical care capacity was exceeded again, but we consolidated onto one floor rather than in separate located sites. We had 32 CPAP beds up and running, and we implemented all the new treatments for COVID as many other hospitals. We paused our high-risk cancer surgery, and time-sensitive cancers were managed, but no one else. Outpatients and diagnostics continued, endoscopy continued, and we changed our philosophy that our staff that were measured for being high risk for a COVID area, actually we cohorted those staff into our green pathways. We released our 28 GNA beds through the height of COVID and consolidated the footprint, but we continue to work at 60% of business as usual. And if we can just go to the next slide. And this has not just helped patients for Croydon, this has helped mutual aid across southwest London. And what we're finding is that the patient treatments in a hub speciality are 12% higher than those that are not in a hub speciality. And the mutual aid means that we're reducing variation across southwest London and now can reach across London to support as well. If we can go to the next slide. We're using Model Hospital and the quality improvement methodology, which is available on Model Hospital, and I would encourage everyone to use it. We can go to the next slide. The difference it's making is if you look at our theatre utilisation, and our theatre utilisation is normally somewhere between 60 and 75%. By actually sharing data and putting in a different strategy, we can see a stepwise change of what we're doing. And our theatre utilisation now is 84%. If we can keep going. And I'm going to ask you to go forward a couple of slides for me. Just to this one, thank you. So if you can just go back one, I do apologise. And what we're finding is the metrics have improved, not just in elective care, but also in emergency care. What has also happened, the journey continues, what has also happened is we have the same concerns with third wave, fourth wave as everyone else. But the exhausted workforce are resilient to a degree because they are doing things as normal and because they're involved in the innovation. Training at Croydon is, if there's elective recovery, there's educational recovery. And every theatre list should be a training list. And I know if Lola was here, she would be saying, no training today, there will be no surgeons of tomorrow. By supporting elective recovery, we are absolutely supporting the recovery of training, and that's really important. So, Neil, thank you for allowing me to speak. And if I may, I'll hand over to Saf Banerjee.
Thanks, Stella. Thank you to the college for the invitation. So I think it's quite amazing that the lessons that Stella has proposed, a lot of it is mirrored with what we did in outer northeast London. And here I am today presenting what our services have done, our division has done, and our trust has done. So if we move to the next slide, please. So it is very, we know that surgical services for elective work has had that stop-start, as the President mentioned, and it's also mentioned in the New Deal report. That's been going on for years. What is quite interesting is after the first wave of COVID happened, our acute physician colleagues came up along and said, hang on, you really need to invest in elective care. And that was a sort of a game changer as well, because something that we as surgeons who enjoy our elective work as well as emergency work realized that there was now an overwhelming sort of support, not just from the surgical team, but as a trust, as an ICS, to move towards supporting elective care. We had an interesting situation, and we're not fortunate enough with the way Croydon had the ability to create the elective site, but we had two sites, as I mentioned. We had Queen's Hospital and King George Hospital, and we had the ability, therefore, to turn King George Hospital into the elective hub. But that required a lot of remodeling. So we had different surgical specialties, including general surgery that had acute on-calls at two sites. Similarly for urology, and we took a leaf out of our orthopedic colleagues who had done something right many, many years ago in having one particular site as an elective, another site as an emergency site, and we just did that for all the services very quickly. We used the methodology, and as Stella mentioned, she's the GERF lead for general surgery, of how we standardize, harmonize, and optimize, and our trust participated in the process with NHSE. And that led to the high volume, low complexity planning, and at the same time, the low volume, high complexity. And during the first wave, we had to continue doing our P2s and our cancers outside, and which was a tough, actually, proposition, because we were splitting our workforce across a number of different sites. But as a number of times already mentioned during this webinar, that necessity is not the mother of invention anymore, it's the mother of innovation. So our orthopedic colleagues came together and created a stellar week where 135 arthroplasties, of which 85-day cases were done in 1 week. And then endoscopy, which is part of my remit, we followed that by increasing our productivity by 47% and helped the trust reach the phase 3 target from NHSE. Next slide, please. So this is what we're doing currently. It's quite busy. That's because we're doing a lot. I think we have a really diverse workforce, and our Academy of Surgery was recommended in the diversity report from the college. We obviously have HEE trainees. And in fact, again, Lola would be proud if we actually say almost all our HE trainees at the ARCPs have reached their the milestones, and they've been able to achieve their competencies. Our prioritization has become standard. We have effectively managed the P2 cohort following the second wave and during the second wave. And in fact, for colorectal, from the trust, we led the CRG meetings and allocated appropriate sites for in the independent sector where the patients would be treated. And since then, we have had significant reduction of these people who have waited. These patients, ultimately, that's what we're here for. The current, so we're midway through this current project, which is Project Scalpel. And we've done about 3 days of weekend outpatient activity. And we've got 3 more days. And between all these days, we aim to sort of see at least 1,000 patients. The green pre-assessment process is now in place, and we're running 15 theatres with near 100% business as usual. For our allocated theatre sessions for trainees, we also have the extended surgical team, and something that the New Deal mentions about surgical care practitioners we're looking into. And the outpatient work that we've always done has changed significantly for everybody. And almost 90% of our 2-week wait referrals are now triaged virtually. And similarly for the 18-week wait patients, for about 32% of them. Next slide, please. So this is what we're heading towards. And this is a phrase that we've coined from the Trust, an elective care village. And that has to be with the strong integration with the ICS, with mutual aid. Now we've got that in place for endoscopy. And it sounds like Stella with the model in South London seems to be further ahead. There's a very harmonized pathway for consent that is also being created again through the HVLC team. And now we're sort of pushing towards the community diagnostic hub development at the elective care village. And this is based on the Richards review, which talks about the need for the diagnostics to be also based in a site which is not acute. The training academies are being developed, and that includes the endoscopy training academy and the imaging training academies, and that's what we want to focus on. Our urology team are sort of training nurses for prostate biopsies, which again helps clinicians of all sort of levels work at the top of their license. Now the orthopedic team are never to be outdone, and they're thinking of another week. They've done the they've done the lower limb already, and they've done 60 operations with about 94% efficiency. We've got a couple of robots in place, 2 Da Vinci, and so we're really creating something which is special. But at the same time, we're also not forgetting the emergency side, which is running really well. So next slide, please. So I really want everybody to focus on the title of the slide because positive energy is important. At the same time, I think what is quite critical to appreciate is that what has been achieved with determination and grit. But that is only possible if there is investment on workforce, on beds, and on training. And we've got to do this together. And at the same time, whilst we can be pat ourselves on the back that we've been shortlisted for 4 HSJ Value Awards, what is very critical is that persistent investment in what is required. So that's from me, and I'm going to pass you over to Tamora.
Thank you. So yes, I oversee a small team at the college, and our job is to get political support for the college's recommendations and to publicise our recommendations through the media, and those two are complementary aims. Next slide, please. So here you can see the parliamentary debate that happened in May. So Peter Dowd, the MP on the left, is a Labour MP who co-chairs the All-Party Group for Health, and he very kindly tabled a debate in Parliament for us. And on the right is the Health Minister, Ed Argar, who is answering him. And so Neil and I will be heading off later this week to meet Mr. Argar and discuss further how to secure the support of the government for the investment that Saz has just talked about. And I hope you'll have seen in our Friday political update email that members of the House of Lords are also debating our report and urging government to adopt our recommendations. Next slide, please. So on the day, to make sure that we really generated a lot of awareness of the recommendations in the report, we agreed to do an exclusive interview with Hugh Pym, who's the BBC's health editor. And he interviewed Neil, you can see on the right here in front of the new building, just free from its hoardings. So hopefully you caught that on one of the BBC's news bulletins that day. We were the lead story on the BBC website, which is now the most visited news website in the world, and also on programmes like the Today programme. Next slide, please. If you weren't opening a paper or surfing the internet that day, then do take a look at the opinion editorial that Neil wrote in the Times that you can see on the left here. And this was really aimed squarely at government, trying to make a very clear case about why the case in surgery, why we need investment in surgery to restore timely access to surgery. And indeed, all the national newspapers ran it more or less, The Guardian, The Independent, The Telegraph, The Daily Mail. So it was quite hard to miss on the day. We had something, an amazing number of mentions in the media, 677 media mentions with a total reach potentially of almost 500 million people. So we were very pleased. Our small team had worked very hard and we were very grateful to the surgeon on the day. Alongside Neil, Professor Vivian Lees and also Mr. Tim Mitchell took part in interviews. And the importance of media coverage like this really is that it does make the politicians sit up and notice and listen, because of course they care deeply about having the support of the public. And so the Secretary of State, the Secretary of State at the time, in a meeting with us said he thought surgical hubs were a great idea. And we went on to brief his team of advisors, and of course now have written to the new Secretary of State, who we hope to meet in the very near future, Mr. Sajid Javid, and want to continue that relationship and really press the case home for the investment that we saw in the autumn in the comprehensive spending review to be repeated for the next few years. And besides that, we will be pushing for amendments to the health and care bill that's been published just today. So that's the sort of work that the team do on behalf of the college. So next slide. I just wanted to say that it's not just in England that we're working, of course. The New Deal campaign is equally underway in the devolved nations because health policy is devolved. So in Wales, over 500,000 people are waiting for some form of hospital treatment. And in a population of just over 3 million, that means 1 in 6 people. So we published a report specifically tailored for Wales, and our recommendations for the health service there were published in March because we had to get that out before the Welsh Senate elections, which happened in May, because as a charity, there are risks associated with publishing policy documents when there's a national election campaign underway. But as you will know, I'm sure, with all our campaigning, we're not party political at all. We ask politicians from all parties to get behind these recommendations in the interest of patients. Next slide, please. So the plan was similarly covered extensively by the Welsh media, and the college's director in Wales, Mr. Richard Johnson, has already met with the new health minister there, Baroness Eleanor Morgan, and she said that waiting times are her top priority in her new job, and has agreed to some of our recommendations, for instance, holding a joint clinical summit on waiting times in September. So there's a lot of overlap between these reports that we've published, and they're all available on the website. Really, the next step in Wales is to get surgical hubs established. So next slide, please. In Northern Ireland, we've published a report too, because health policy is devolved there, of course, to the Northern Ireland Executive. And sadly, Northern Ireland actually has the worst waiting times in the UK. They have 1 in 4 people on the waiting list, and some of those people are waiting 4 or 5 years. So it really is a very difficult situation for the people of Northern Ireland. The Northern Ireland Health Minister recently said it would take 10 years to sort out the elective backlog. So we called our policy report 10 steps, not 10 years, to try to present solutions. And similarly, we're recommending there a number of steps which will sound familiar by now, like multi-year investment and COVID light sites. Next slide, please. So the report was widely welcomed by Assembly members from all of Northern Ireland's main political parties. The Health Minister, Stormont's Health Minister Robin Swan, by members of the Health Committee like Pam Cameron and Colm Gildenew there, who chairs Stormont's Health Committee. And Mr. Mark Taylor, who's the college's director in Northern Ireland, has been tireless in agreeing to media interviews as well between his operating lists. So thanks to his regular meetings with the Minister and officials in the Northern Ireland Executive and the support of his board, they have got a COVID light elective hub established now, and they have effected some real changes in how and where surgery is taking place. And they're really making some great progress on improving the sustainability of services. Next slide. Thank you. So if you're interested in getting involved in the campaign, it's not over. It will be running through the year. Please do drop an email to our team because we can support you to connect with your local MP or member of the Senate or Assembly member. And we really need your support because politicians listen to doctors, they listen to their local constituents, and their support is really key to winning the investment that surgery so desperately needs. Thank you. I'll hand back to Neil.
Thank you. If I can have the next slide, please. And Lola, had she been here, next slide, please, would have presented this slide from the trainee perspective. Stella's already said no surgery or no training today, no surgeons of tomorrow. And of course, from the trainee perspective, COVID had a massive impact on training, and we're still seeing the effects now with the trainees' logbooks and reports, etc., being much worse than they might have been in normal times. That figure of nearly 1 million elective training cases lost is staggering, and we must, as much as we possibly can during the whole recovery phase, ensure that training is an integral part of recovery. Next slide, please. I think that's probably the last one. We're going on to questions now. I'd like to ask all of you in the audience to send in some questions if you would, but in the meantime, we'll get the ball rolling with some questions to the panel. I thought those are some really brilliant and stimulating presentations, and I've got lots of questions to start off with. First of all, Stella Wieg, a number of our cheesed off colleagues working hard, trying to get up to business as usual, struggling, finding it all too much. Surely you must have very enlightened management to help you do this. What's the picture? What's the story?
I think there's a real desire to do in Southwest London, Neil. We're blessed. We've got one teaching hospital. We've got joint appointments between many of our hospitals. So I think the framework has already been there. But what is very, very different now, the tone is different. So the tone, Sass is in a clinical director role as I am, and the tone has always been about performance management and targets. This now is actually listening to the clinical voice in terms of what can we do differently and how do we allow surgeons to have ownership again of the patients that they treat, the list that they are involved in, the listing of patients. all of that is suddenly back to where it was, Neil. When I qualified in 1991, that's what a consultant surgeon would do. And somehow along the last 20 years, we've lost the ability to have that surgical ownership. I think we have it back now, and there's a real opportunity, and we mustn't lose it, to have that clinical and operational voice absolutely joined up together. And to surgical colleagues who have been very, very frustrated at process, some of them are finding there's a little bit of light at the end of the tunnel now.
Yeah, and I think stories like yours give a bit of hope too. Can I please ask about one particular, that is the children's area, the Dolphin ward, 10 beds. Is that paediatric surgeons doing the work, or is this general surgeons in inverted commas with a pediatric interest? Because of course, one of the things we've not spoken about today is the massive children's surgery wait list, which has been badly affected by the pandemic. How are you managing that?
So we've always had a 12-bedded unit where children are admitted and discharged, day case work only. Croydon has inpatient beds, but really only for emergency and paediatrics, not for paediatric surgery. We have visiting surgeons from George's for urology, general surgery, and we've got joint appointments for ENT. We run a paediatric for South West London. For paediatrics at Croydon. That's a real benefit for. Through the second wave of COVID, we had to stop doing paediatric work from emergencies because we needed those beds for inpatient time-sensitive cancers.
So that's great. So if any of you out there are planning something like this, do remember to make a special provision for, if you like, everyday paediatric children's surgery. One last question, Stel. Not everybody will understand what you mean by the model hospital. I wonder if you could just expand on that a little bit for some of our listeners who maybe don't know about it.
Yes, it's a fantastic resource, Neil. So model hospital has been around for 7, 8, 9 years, but it's not been used very well. It gives us model metrics. So if you had a perfect hospital, what would be the best practice in a hospital compared to the hospital? It has now reinvented itself. So afterwards, at the time, did a roadshow, pulled data, gave us data 3, 4, 5 years ago that showed clinicians for the first time their outcomes, their volumes of work, and how they compared with their peers. But it was often historic data. What we now have in model hospital is in-time data, which is either last quarter or last month, and it gives metrics in terms of emergency standards, elective surgery. So, for example, in general surgery, data that's contained within NELA, the National Elective Laparotomy Audit, information that's in ENBOCAP, which of course is the colorectal cancer audit, management of articular disease, appendicitis, inflammatory bowel disease. But it also gives per organisation the ability to look at your own data and compare with your peers, your theatre utilisation, your staff management, your finances, your governance. It is a rich site of information, and it's open to everyone. So to trainees, anyone who wants to look at it can look at the data. It's invaluable, and it really allows you to put things in place and actually measure the change. So he's very about and wants to link to that. I'm sure we can send that out through all of college guidance.
That would be great, and a link to it and so on. That'd be absolutely super. Okay, I'll give you a rest, Stel. Thank you very much for those comments. I'm going to ask Sass now. So this elective village is called Sassville, is it, Sass? I'm pulling your leg, of course. I think it's a terrific idea. It sounds absolutely wonderful. But can I ask you the same question? Have you got enlightened local management to allow you to make that sort of innovation and get everybody working together like that?
I think Stella has given my answer away, which is that there has been a sea change in the way management clinicians are working. There's a real push for a clinical leadership. And I think the magnanimity of what we face as a nation, each organization is realizing that no one can do it alone. And I think especially as the NHS has shown with the healthcare professionals working through COVID, that you do require that clinical voice. And that is what has been recognized in our trust. And it has required a couple of very determined individuals saying that we will push through barriers. There are barriers everywhere, but that's what has actually happened. So I encourage everybody to actually find that voice of innovation and engage with the management, the executives, who are all willing to help.
And Sas, what about colleagues? We know that whenever the brand new arrives, we have some colleagues who are early adopters and some who are extremely slow adopters, shall we say. How have you managed to charm them into the scheme?
I think we sort of had a lot of conversations with colleagues, and each service, whether it's ENT, who are currently running a pediatric outpatient week and planning for surgery, they ran the service, they owned it. And similarly for orthopedics, every single specialty has come up with an idea, they've discussed it with their team. The people who are not the early adopters, they've been charmed, because otherwise these sort of results would not have been achieved. Now, I think ultimately the results speak for themselves. So I think that's where we're at right now, Neil.
Can I please ask, you mentioned using the independent sector. Is that still happening? Is that an important way to augment capacity, or have you found another way of increasing beds?
No, I think beds are an issue, and that's something that we really recognize and is highlighted really well in the report. The independent sector, we, especially BHR, were probably one of the first to repatriate after the first wave, and secondly after the second wave. And following the second wave, we were actually, when we were leading the CRG for colorectal, we did offer the possibility of mutual aid for other providers within North East London to also come across. But thankfully, most providers were able to get their beds fairly soon. But I know that there are other providers still having to use the independent sector for a fair length of time. I don't think the reliance on the independent sector is right. And I think just the division of the elective and the acute site and an increase in beds, and ultimately, I'm sort of backing the report 100%, but I'm not saying that because I have an affiliation with the college, but because we've seen how our patients have benefited and what we believe is right.
And then just one question, I'll give you a little rest. You were lucky you had 2 sites. If you hadn't had 2 sites, what would you have done?
If we didn't have 2 sites, I think there are ways to actually have a silver model and a bronze model and a gold model when COVID really came along. And you could find a way to actually still look after the patients with the right IPC and be able to provide COVID minimized pathways. So I think it's still doable, and COVID is hopefully going to be a distant memory soon, but flu seasons have come and gone. And as I mentioned, that we've stopped elective work every single time. But this particular aspect of being able to make a decision as a group, as a trust, as an ICS, that it is important that we preserve elective work whenever there is a sort of a winter surge, or whenever there is something that tickles the NHS, that is the important principle.
Thank you very much. I'm going to ask Tamara now. First of all, about the report itself, there's a kind of tension between providing too much detail and then the broad brush so that people understand the principle. Is it not too complicated? How do you think you get to that point? What's the sweet spot, if you like?
Well, I think as with all our kind of communications work, what we try to do with the report is be really clear about who the audience is. The primary audience for the report is politicians, and that does mean it has to be understandable for politicians who may not have a background in the health service. So working with the policy team at the college, you know, I'm well aware of the array of terms that are in use COVID light, green, hot, cold, and so on, to bring that into the public domain, and particularly to bring it into the media domain, we do have to simplify things down a bit, and hence we're talking about surgical hubs, even though that is a general term within which you might be talking about high volume, low complexity work, or specialist hubs, etc. So yes, the job of the team is to bring it up a level to make sure everybody can understand it. If you've ever looked at a Flesch-Kincaid score, that's a brilliant way to understand just how easy it is for somebody else to understand what it is you're writing. So that's the task that the press office team and I have to go through. And actually on that subject, I'd really like to thank Saz Banerjee. Thank you so much, because your support, and it's a lot of hard work behind the scenes on this occasion. Thank you for bringing to us your colleagues at Redbridge, because being able to talk to those colleagues and being able to get some filming in as well actually brought this story to life for the media, and that was really key to getting coverage on the BBC. So my press office colleagues have said please to thank you very much, because it's a lot of time and effort, but I hope it all paid off in this case.
Okay, most of our, probably, I'm not quite sure, but I'm going to make a gross overgeneralization. Most of our listeners, attendees, watchers won't understand the process about the Treasury's decisions over funding. I wonder if you could just talk us through a little bit exactly what happens. Give us an education in how the Treasury looks at funding for the health service.
Well, I'll do my best. So what we saw last autumn was a comprehensive spending review, which set out the money the government would be spending. And that's a regular process that happens, and we'll expect to have another spending review this autumn. And that may just be for a one-year spending announcement, or historically, sometimes they've gone into multi-year spending announcements. So the key thing for us is to influence that decision making. I mentioned earlier that Mr. Sajid Javid, our new health secretary, used to be the chancellor, so he will be all too familiar with deciding the government spending priorities, and he will be lobbied by he will have been, as chancellor, lobbied by all departments. All the different government departments will put together their case for how much money they need to spend to deliver public services, and that process will start this summer. And that's why it's very clear and important that we had that headline message of continuing the elective recovery fund for a further 5 years, but pointing out that that's only really a start. So that 1 billion that does support and incentivise trusts who can achieve 85% or more of activity is really important. But of course, actually in government spending terms, 1 billion is not a huge amount, and above and beyond that, our report explains that we do need government to invest in increasing the number of beds up to the OECD average, and indeed the number of medical staff also. So this is, when we look at the wider spending envelope, that's where we really rely on the modelling and the projections that are done by organisations like the Health Foundation and the King's Fund, who really are talking about something in the degree of a 4 or 5% real terms increase for the NHS as a whole. But I think that what's interesting here is that our report, although as you would expect it was really focused on surgery, also it did embody a very collaborative approach, and that's why we saw the support of the Royal College of Anaesthetists, the Royal College of Emergency Medicine, because of course what we don't ever want to do is to descend into an argument about which part of the health services it most needs the money, when the true picture is, as I think everybody knows, is that you know, if you take away from one part, then another part will suffer. So really what we're talking about here is about the overall case for investment, and indeed the report makes the point that we're not just saying that more surgeons are needed or more surgical surgical teams, that indeed we're looking across the system at an increase in the healthcare workforce, particularly because more people are choosing to work part-time as well.
Yeah, great. Tomorrow, I'm just going to give you a little rest so you can look at the questions that have come in and choose the juiciest. I'm just going to go back to Stella Vig a second. Stella, what about capacity in your neck of the woods? Was there a problem with beds? Is there now a problem with beds? How have you managed it?
So I think there's an ongoing problem with beds. I think the report highlights the demanding capacity that we've all known about for many years, and it now needs to be readdressed. There is no doubt that we can do more, and that, as you say, tomorrow, it's collaborative. It's about surgery and medicine working together and actually seeing where we can ensure that patients are looked after well, but actually perhaps on a day case visit, on an ambulatory pathway, patients don't want to be in hospital unless they really have to. So how do we reinvigorate services that fall around those patients and support them and actually keep them well at home, even if they're recovering, or actually have, let's say, for example, diverticular disease that could have antibiotics at home rather than having to be in hospital to have your antibiotics. So I think there are things that we need to do, but the demanding capacity is not right. We are about to, in Croydon, invest in a brand new intensive care unit, which is going to take over 2 wards. That conundrum of how do we use the space at Croydon to facilitate more beds in the height of a further impact of COVID. Flu will be on its way. We don't know what the mutations are going to be. It's going to get tricky, Neil, but what can't happen and mustn't happen is that elective care comes to a standstill in the way it has through what has been described by previous presidents as an ongoing winter crisis and an ongoing winter of Narnia for surgery. It can't go back to that. It must be different.
Yeah, one of the meetings I was in this last week, some of the senior NHS people were saying, we're not talking about winter anymore. It's like this all the time. Tamora, we have some questions from our attendees.
Yeah, sure. So I've got a question here. The report talks about nurses and anaesthetists. There's a plea. Please don't forget the operating department practitioners. Equally as important, members of the theatre team with lots of skills and knowledge to offer. I wondered if there were any comments about how operating department practitioners are taking part, participating in some of the models and examples that we've just heard about.
So SAS, the extended surgical team.
So the extended surgical team is currently comprised of ANPs, of which some of them have gone on to develop surgical care practitioner skills. But a fair number of our extended surgical team have got fantastic skills from previously working in theatres, working in critical care. We don't have any colleagues working as ODPs or as the short form would be. But I think the question is absolutely right, Tamora, that every single person in the theatre team, and not just the theatre team, going back to the admin, and over the course of this pandemic in the last year, we've realised how critical it is, just not from any one particular person within the theatre complex, but the admission staff, how critical their sort of contribution is. So in terms of our ODPs, they have absolutely the right to sort of be recognised, and we certainly value their contribution.
And Stel, in Croydon, extended surgical team, have you been creative in that area?
We have, and we've also been, so the ODPs, I think, tomorrow have been absolutely different in terms of what we've done, because of course, because of their multi-skills that they possess, they've been our frontline in critical care as well for support, because they are akin to the American anaesthetic fellows, which are non-medical. Our ODPs are probably the closest that we come to that. And so they've been absolutely incredible and invaluable. But we not only have we looked at ODPs, we're actually looking at HCAs and medical support workers, and actually increasing the scope of what people have done. And Neil, you talked earlier about people wanting to leave the profession. That's just not in the medical specialities. That's across the board. People are feeling tired. They want to do something different. And in terms of appraisal and development, we've not really invested in our staff groups. And this allows us to, for example, we put in 4 level 1.5 beds into our surgical ward. Suddenly we've got an ability to recruit nursing staff because they want to do something different. They want to be valued for the skills they have, and they want their skills to be developed. And so for us, it's part of our recruitment and retention strategy now. Absolutely critical to what we're doing.
Great. All hands to the pump. Tamora, next question, please.
So the next question, how is the NHS planning to utilise current and indeed potential international medical graduates?
Well, we hope better than they have done in the past. Sas, do you want to start off on that one, please?
Yeah, thank you, Neil. I do happen to have a interest in this because for the ISTP program, I'm one of the clinical leads for general surgery for the college, and the international medical graduates who've come to certainly our region through the ISTP program, they have been frontline in sort of the way we have sort of deliver emergency care as well as elective care, and throughout the sort of wave 1, wave 2, their training and their competencies have not been ignored. There is a bit of a question right now as to what we do with potentially countries that are in the red list, but at the same time, I am aware of international medical graduates that have come during the current period and who are having to sort of go through the right process to make sure that they are complying with government regulations. And so they are integrating well with the providers that they are going to. So the very short answer after a long-winded bit is that they are welcome, and we sort of really learn a lot from them, and we love to sort of have them here.
And Stel, any further comment on the issue?
They're welcome. They are essential, Neil. And if we think about, it's very easy to be in a single country and to train within that community and to progress through your career. It's actually a very brave step to move into a completely different training environment and flourish, which many of our international medical graduates do, and become consultant colleagues. So very much welcome, intrinsic to what we do, and are valued and respected.
Absolutely. Tamora, maybe last question, if you can choose the best.
Okay, this is in a different area. I believe it's about one of the stats on Lola's slide. So with that caveat, there is a question around how there are 900,000 elective training cases lost. How is that happening? Is it because of a lack of resources? Is it a lack of funding? Or is it because the focus has shifted away from training?
I think it was mainly when surgery just stopped completely, when elective surgery stopped completely. But Stella, I wonder if you can have a comment on that, please, Stella.
Neil, I think you're absolutely right. I think tomorrow that's really elective surgery just came to an absolute standstill last April, and actually didn't get going again until July, August, and even then not at 100% of what we were doing. So it's not that trainees were excluded from it, just that it didn't occur. And I think the college stance and Health Education England and JCFT has been absolutely co-aligned with ASSET and BOTA. As we operate on individual patients, having had permission, we ensure that we perform those operations with our trainees, supporting them to be our consultant colleagues of the future.
Well, I'd like to thank you all. I'd like to thank our panelists very, very much for a very stimulating conversation around trying to recover well around our new deal for surgery. As Tamora has said, this is an ongoing campaign. We need to change hearts and minds at the centre of government and the Department of Health. We'll keep trying to do that on your behalf. I think we'd like to hear all the time your views around surgical hubs, around what it's actually like working in your environment, things that you're finding tough. Please let us know. Many of the questions you've asked, we'll get back to you over if they haven't been rehearsed already with the panel. Thank you all for attending, and thank you again, all our panelists, for a great show. Thank you very much indeed. And with that, we'll say good night.
Thank you.
Thanks. Good night.
Good night, everyone.